This is the One Thing Podcast, and I'm your host, Dr. Adam Rindy. The One Thing Podcast brings together leaders in functional and naturopathic medicine to discuss actionable information that may unlock puzzles in the areas of gut health, brain health, metabolism, and longevity. Please note, these episodes do not replace the opinion of your doctor. They are not intended to diagnose or treat any condition. Please discuss this information with your provider and discuss your own unique personal health history before adapting this information. Please subscribe to our episodes so that you can stay on top of the most current information in these areas of medicine. Hey everybody, welcome to the next episode of the One Thing Podcast. As you can see, this is a episode focused on addiction medicine. I welcome on a colleague and special guest, Dr. Ravi Chandiramani, who is a naturopathic physician with over 15 years of experience working with those struggling with addiction and alcoholism. He's also the founder of Integrative Addiction Medicine, otherwise known as IAM. This is a model that he will speak about in the episode that is an integrative approach towards addiction medicine. We go into a lot of things in this conversation. One of the most potent aspects of this conversation is talking about all the different myths and beliefs behind those who become addicted. We talk about why people have addiction, what is the normal process and flow that leads to addiction, and some of the struggles of addiction. We also have a very deep conversation about what it's like to be a caregiver of someone who is addicted or having an addiction. We talk about the difference between process addictions versus substance addictions. So this is a very important aspect and understanding that will help us understand some of the modern addictions and process addictions that we see in today's society. This conversation may be triggering for some. I do think that it's very fair and also complete with just sort of a balanced view towards addiction medicine. Preventing addiction is not what we cover in this topic. This is really focused more towards people who are dealing with addiction and their loved ones who are caring for them or walking alongside those who are addicted. In future episodes, we may discuss prevention and genetics and other aspects and also treatment of addiction. But purely, I invite you to sit back and just hear what it's like to be in the trenches with some people and patients who are struggling with addiction and really hear from an expert some of the realities. And I think you'll walk away feeling better understanding and a whole lot more compassion towards the process of dealing with addiction. So without further ado, welcome to the next episode of the One Thing Podcast. Dr. Ravi, welcome to the One Thing Podcast. I'm delighted to be able to speak with you today.
Thank you for having me. I appreciate it.
You're welcome. So I've been on a little break from the podcast for about a month, so I'm excited to kind of get back at it and start talking about some topics of interest. And today's topic has been something I've thought about since I started the podcast, because it's such a big, important area of health and society and so many different levels. So we're talking about addiction, and this is sort of your expertise. Just would love to start off hearing a little bit about how you got involved working in addiction medicine.
Entirely by accident is the answer to the question. Most physicians find themselves in this particular field either completely by accident, like me, or because they have some personal history of addiction or had somebody in their family who has some personal history of addiction. I was actually intending to do family practice. And, in the process of building a practice and looking for moonlighting opportunities, I happened upon an ad in the newspaper for something called a medical liaison. I didn't even know what that meant. I responded to the ad. I met with an individual who was conducting interviews and came to find out that they were hiring for a private drug and alcohol treatment facility in Scottsdale, and that they needed a physician. And so it happened that I saw the very first patient admitted into that program in 2004. And gradually over the course of the next 6 or 9 months or so, found myself spending more time at the drug and alcohol treatment facility than I was trying to build a family practice in Scottsdale. And so here we are some 18 years later, some 50,000 patients later. And my practice has been exclusively dedicated to this demographic in that time.
And did you have a philosophy going into your work, or was it sort of was your philosophy kind of influenced by the facility that was in place? Like, how did you even get started, kind of like understanding a framework of how to work with patients?
It's a great question. I knew nothing of what I was getting into. Certainly, as is the case for most physicians, maybe not now, but when I trained and my mentors trained, we had no exposure in medical school to the treatment of addictive disorders, and so in the early days, very early in my training, I depended largely on my mentors who had been practicing addiction medicine on an inpatient or outpatient basis here locally in Arizona for some time, and made themselves accessible for my questions as they came up in real time. And believe it or not, it wasn't uncommon in those first days for me to do a history and physical exam and walk into the next room saying, "What do I do?" with the patient, and having my mentors say, "Well, you might try this or you might try that." And now, much later, the nature of the interventions that we use, the pharmacologic interventions that we use, is fairly standard. So I mean, we're dealing with the same from a medication standpoint. You're dealing with the same 20 or 30 things.
Yeah.
And so just having all of that experience now behind me and understanding when those particular tools are best suited for a case, now that's kind of rote and secondhand, but it certainly wasn't then. What I did realize very early on, though, was that what I was dealing with was a multifactorial disease process. And from my training as a naturopathic physician, what I knew is that a multifactorial disease process is best managed with a multifaceted treatment strategy. And I also knew from my training that that I would be remiss if I treated every heroin addict the same, and every alcoholic the same, and every methamphetamine or cocaine addict the same. In fact, what I was dealing with was an individual who found their way to this disease process through a very individualized journey, through very individualized life circumstances, and that individual required a very individualized, customized treatment strategy. And that is the essence of how we are trained, and how we are trained to look at our patients. And so very early on, I recognized that there was an inherent synergism between how I was trained and my ability to be effective with these patients.
Gotcha. Okay. And so, like, with the different models out there, kind of hearing sort of you're alluding to like a biopsychosocial model where it's like a little bit of individualized treatment direction. Is that the model you follow, like for treating addiction, or is
Yeah.
it something else?
Well, it's kind of it's kind of a hybrid. It's certainly not this moral model, right? Where you're the reason you're addicted is because you're morally weak, and if you only accepted responsibility and accountability, then you could find your way out of it. Certainly isn't that, and it certainly isn't. I'm not dealing with a Medicare or Medicaid population either, um, so we don't focus on kind of the socio-cultural things as much as Medicare and Medicaid specific programs would around economic inequality and housing inequality and these kinds of things. It's probably a combination of a biopsychosocial model and and kind of a disease model, right? An addiction as disease model, which is largely the model espoused by the medical community, and certainly the model espoused by the ranking authority, for lack of a better term, the American Society of Addiction Medicine. Um, the disease model is the model thoroughly espoused there as well. So it's probably a combination. You add to those established models the tenets and principles of naturopathic medicine, and um, and that's how I practice.
Mm-hmm, mm-hmm. Yeah, and so I think there's a lot of confusion as to like what that means. Does that mean not the way you described it, but just in general? Like, does that mean it's like these are genetic, biochemical underpinnings of addiction that is a big part of your focus, or is it something else?
So I mean, to be sure, the evidence is very clear that there is genetic predisposition, and certainly when we're, for example, many of the patients that I treat are tribal members,
Mm-hmm.
right? American Indian tribal members, Native American
Mm-hmm.
tribal members, and um, and we have a ton of evidence that demonstrates genetic predisposition to alcoholism in that patient population. We have ample evidence in other populations and subpopulations as well. And so I certainly see that. We almost assume that, right? But you're looking at the individual, right? You know about the genetic predisposition. You certainly get that through the history, but you find out through spending time with the patient and developing some clinical rapport with the patient those unique circumstances that that led them down this particular journey,
Mm-hmm.
right? This particular path towards addiction. And what we know now, I think, that we perhaps didn't have as well defined when I first started, is this notion of trauma-informed care.
Mm-hmm.
Meaning specifically that, I mean, there's some experts, quote unquote experts out there that would go as far as to say um, every case of addiction is contributed to by trauma of one form or another. If you are unaware of it, it's only because you haven't looked hard enough,
Mm-hmm.
right? And so having as part of your treatment team therapists that are skilled in these modalities, in trauma specific modalities such as eye movement desensitization, such as somatic experiencing, such as motivational interviewing, and all of these evidence based modalities that exist and um, and are particularly effective in a population suffering from the manifestations of trauma, for a lack of a better term,
Mm-hmm.
right? And so that certainly factors in on a daily basis.
Well, that makes a lot of sense to me. I mean, you hear these different philosophies on addiction, such as, we self-medicate.
Mm-hmm.
Um, we're looking for a way to heal from pain.
Mm-hmm.
We're looking for a way to connect with a part of ourselves that's been taken or been through trauma, or been violated, or so that makes a lot of sense. And it's really refreshing to know that that's included in the philosophy, because and I imagine that for some people, like you were saying, it's pretty obvious, and for some people this is like stepping into a doorway that they've never opened before.
That's right. And so it's incumbent upon the professionals that they are seeking help from to create that safe environment for them to, perhaps for the very first time, delve into some of that. And the treatment facilities that have the better outcome rates are adept at doing that.
Yeah. And, I think anybody who's listening to this podcast, has probably in one shape or another has faced addiction, either themselves or with someone who's a family member.
Mm-hmm.
And so I think there's like some myths that I would love to kind of bust about,
Sure.
Yeah. Who you work with. And, you said you work with, the Native American population, but just in a general, like, people that are seeking care in addiction medicine, can you just kind of go into some of the myths of like reality versus some of the things that people like might perceive as who's seeking treatment?
Yeah. So this whole moral weakness nonsense, right? Not true. Also, this notion that abstinence is the only cure. Also not true, right? We have FDA approved pharmacologic interventions that are specific to addictive disorders that we didn't have 20, 30 years ago.
Mm-hmm.
And those things fit neatly under a larger umbrella heading of harm reduction.
Mm-hmm.
We're starting to hear, now this idea of, needle exchange programs and allowing individuals safe spaces to inject and providing safe syringes and needles and decriminalization and all of these things that you hear about. But on the medical side, when we think of harm reduction, we think of FDA approved interventions. And so for opioid use disorders, we have several things. We've had methadone forever. We have buprenorphine now, which works very well. We have naltrexone-based therapeutics that are effective for some people where buprenorphine and methadone may not be. And so on the alcohol use disorder side, we also have Vivitrol. It's dually approved for opioid use disorder and alcohol use disorder. We also have acamprosate sodium. We had disulfiram for a really long time. And these things are specifically approved for addictive disorders. And so there are some people that are are not great candidates. I mean, yeah, is abstinence ideally, where you want to land? Sure. Getting individuals to that place is very challenging, and for some people, it simply boils down to a question about which is the lesser of two evils.
Right.
Right. Putting that individual in a position to continue to endanger their life on a daily basis through injecting drugs into their system, or providing them with FDA-approved medications that serve as effective tools from a harm reduction strategy.
Yeah.
And a harm perspective. And so
Yeah.
more and more in the conferences, the addiction medicine conferences, always looking to better and more effective harm reduction strategies.
Right. Right. It makes a lot of sense, from standpoint of individualized care, because like if you're coming from like some type of dogma, where you're, having people kind of sign up for your philosophy,
Mm-hmm.
and like the failure rate must be much higher versus if you look at the person in front of you and say, I want you to succeed at this in the way, taking all the judgment out of the room or moral conditioning out of the room, and what's going to help this person succeed at
That's right.
this.
It's kind of like playing matchmaker, right? You're with that individual. You know that individual. You know their story. You probably know what's worked for them in the past and what hasn't. What their triggers are, at least the ones they've identified. And now you're in a position to matchmake. And by matchmake, I mean, okay, these are the tools. This is the toolbox. It's got 3 layers. It's got some drugs in there. It's got some non-drugs in there. And here's the patient. And so utilizing that time that they're in treatment to familiarize them with those tools in the toolbox and give them the opportunity to practice using them before you set them loose.
Yeah. Yeah. So going back a little bit with just how people get to you in the first place,
Mm-hmm.
like what are, I mean, is there sort of a like steps to addiction that you see that are kind of accepted as, more universal, or is it just sort of all over the map about how people become addicted? Like what do you generally see?
So certainly that role of trauma factors in. It could be childhood trauma. It could be trauma that occurred later in life. It could be physical trauma. It doesn't have to be physical trauma. It could be emotional trauma. It can be, spiritual trauma. It can be things that people don't even necessarily think of as traumatic. And it doesn't really matter what anybody else thinks, as long as that individual perceives it as trauma. That's all that matters. And so it's genetic predisposition. It's who they spent most of their time with as children, as adolescents, as young adults. It's whether they have had secure housing for their lives. It's whether they had one or both parents or 0 parents around. It's whether they've encountered issues with the law and have had legal consequences as a result of those things. It's whether they've had to spend time in jail or in juvenile detention facilities or things like this. It's how their relationships have worked out for them in life. Do they have a broken picker? Do they make good relationship decisions? Have they bounced around? Are they secure in that? Do they have some sense of spirituality? Are they part of a religious community? Do they have a spiritual practice? Do they, does everyone around them drink constantly or use constantly? It's all of these things. It's any and all of these things. And for any given individual, it is a specific combination of these variables that ultimately leads to them finding that they are dependent, either physiologically or psychologically, or both, to one or more substances. It is that they're experiencing withdrawal if they stop using one or more of these substances, because that's the nature of the beast. Addiction attacks the individual, the brain of the individual, in two ways, right? It will reward you as long as you feed it, and it will punish you if you don't.
Mm-hmm.
And it's doing both things simultaneously.
Mm-hmm.
And so, so they find themselves either dependent, physiologically or psychologically, withdrawing if they don't use these substances, um, checking out of their primary relationships because it's more important to use the substance or substances, not going to work because it's more important to use the substance or substances than it is to hold down a job, finding themselves on the wrong side of their parents if they still live with their parents, who are unwilling to tolerate the behavior any longer. Any or all of these things ultimately lead them in the door. This segues nicely, though, Adam, into one of your previous questions around myths. It is a myth that you have to be at your absolute rock bottom in order to be effectively treated for this disease. That is not true.
Mm-hmm.
You do not need to be at your absolute rock bottom. There are plenty of people that I've treated through the years that had plenty of bottom to go, and made a conscious decision to nip it in the bud rather than wait to see what further consequences awaited them.
Mm-hmm.
It is also a myth that that you must relapse. That relapse is a part of effective treatment for this disease. Also not true. There are plenty of individuals that have been one and doners, right? They come in, they go through an effective treatment program, they never use again. They never relapse. So that is also a myth. Another myth: Alcoholics Anonymous doesn't work because there are no medications involved in that. I mean, it's not scientifically based. It's not an evidence-based modality. Not true at all. There are plenty of people that have found their way to abstinence and recovery through nothing but the fellowship offered by peer support groups, 12-step groups like Alcoholics Anonymous and the like. So all of those things.
Yeah. So, okay. Well, so it seems like what you pointed out was like a number of risk factors and kind of the software that would put someone in a position where they're more likely to become addicted. What about people who, are generally, let's say the trauma was there, they're going through tough times, and they just start like having like an everyday drink or something like that. Like, what about just more of like a milder path to this? Like, how does that happen?
It happens through things like dealing with a global pandemic, right?
Okay.
What we saw as a result of this, and I should say that the long term, the long tail effects of this have yet to be determined. But what we know for sure is that people that were on the fence, right? They weren't quite meeting diagnostic criteria for problem drinking or problem using. COVID comes along and pushes them squarely over the fence onto the wrong side. And so now what we find is a plethora of individuals who meet diagnostic criteria for a substance use disorder where they didn't before. And it's simply by virtue of the fact that they were bored, sitting at home, isolating, right, not being able to interact in the ways that they were, not being able to engage with their religious communities, not being able to engage with Alcoholics Anonymous, everything being virtual, if at all. Having to be there with a spouse or loved one that you didn't have the best relationship before COVID. And now you're with one another 24/7. All of these things having legal access to alcohol, and in many states in the union having legal access to marijuana.
Mm-hmm.
Right? COVID comes along, and that's exactly the catalyst needed or required to push these individuals clearly into diagnostic criteria for a substance use disorder.
Yeah, definitely seen a lot of that in my coming through my practices, and some people who were just sort of they could see it unfolding in front of their eyes,
Mm-hmm.
and it was consciously happening, and then they're having dialogues with themselves like, I'm drinking too much, or I'm seeing this happen, and then they were into it before too long.
Yeah.
So along those lines, like there's this confusion in a lot of circles about soft addictions that maybe have no identifiable chemical that's like binding to any kind of receptor. So, for example, social media or porn addiction, or even like work addiction, versus like kind of the obvious things like cocaine and alcohol, and potentially like opioids and other drugs that have like a real defined biochemical receptor that when that receptor is bound, you can become addicted to that. Can you compare the two? I mean, are we at a point where we have accepted that these other addictions have there's like a chemical dependency?
So, I mean, what you're referring to is the difference between a substance use disorder and a process disorder. Process disorders are like, shopping addiction and gambling addiction and, sex addiction and social media addiction and the like, versus substance use disorders, which are, all the other things, all the things that we typically think about when we think of the word addiction. What I can tell you is that, yes, while it is true that you're not taking in an exogenous substance that's binding a particular receptor in your central nervous system or peripheral nervous system and causing a particular reaction, in the brain's reward center, if I were to, cut an individual in half and look at what was going on in that reward center while they were engaged in a process disorder, let's call it gambling.
Yeah.
Or what happens in that reward center from the very first cue that triggers that individual that precedes the use of a particular substance, all the way through the use of the substance and thereafter. In the brain, it's indistinguishable. In the reward center, it's indistinguishable. And so while you are not taking an opioid in or cocaine in or one of these things in, you are still, the behavior is still being rewarded by the endogenous neurotransmitters in the reward center, namely dopamine. So the behavior is being reinforced by virtue of the fact that that dopamine is being released in the reward center of the brain. The dopamine is playing a role there to reinforce that particular behavior, and so those things, that part of the brain, in the reward center, it's indistinguishable whether it's a process disorder or a substance use disorder. And they are being reinforced. The behavior is being reinforced the same way.
Interesting. And like, their withdrawal effects happen as well with.
Very interesting question. We used to think that that process disorders could not possibly have a clinical withdrawal syndrome, but what we're finding is that there is a withdrawal syndrome. It just doesn't look the same as it does for opioids and alcohol and benzodiazepines, et cetera, which are far more obvious and physical in nature. So, but certainly there is something going on when the behavior is discontinued that may look more subtle, but would look like depressed mood or anhedonia and disinterest in doing things that you previously were interested in doing outside of the process disorder. Those things are very common, and I think, from my perspective, would qualify as a legitimate withdrawal syndrome, even though they're not as physical or obvious in nature.
Mm-hmm. Yeah, I think that's very helpful for people to know, especially, we're kind of moving into an era where in some circles, people are starting to, experiment with all kinds of drugs because of, I think there's like a certain socio-cultural movement where, they're pushing for like just responsible use of recreational drugs and kind of understanding the drug and how to support your body if you're going to use it. Mm-hmm. I think from my generation, that just feels like a slippery slope. And for the younger generation, a lot of people really buy into that. Mm-hmm. People in their 20s or teens. I don't expect you to give me your opinion one way or the other, but any thoughts on that? Because that is a big topic, especially with like psychedelic mushrooms and marijuana is like just using the drug responsibly, and that is a way to prevent from harm or preventing from addiction. Any thoughts on that?
Yeah, I mean, it's, what immediately came to mind when you started talking was when what's the name of this? I can't remember the name of the musician, but she went to treatment and came out of treatment and began using alcohol and cannabis again, and called it being California sober. Right.
Okay.
Right. Sure, I'm sober. I'm just California sober. I drink a little and I smoke a little. And the notion of that, for me, especially for an individual that has required professional intervention at an inpatient level to treat this, is ridiculous. To your question specifically, we don't know squat about the brain. We know very, very little about it. But what we do know is that it's still developing well into early adulthood. And that is a fact, that it is still developing into early adulthood, like 20, 22, 23, 24, 25. And that if it is exposed to these substances during that developmental phase, it's like a crap shot. For some individuals, they'll be perfectly fine. For other individuals, however, it may result in like almost a semi-permanent to permanent psychosis. Mm-hmm. And the same thing it applies to psychedelics. It applies. People think it doesn't apply to marijuana. The fact of the matter is that the industry that is the cannabis industry in this country is investing millions, if not billions of dollars into figuring out how to create the next awesome product, how to maximize potency, how to create ever more potent consumables. And by virtue of the fact that what that amounts to on a quantitative basis is people consuming cannabis products that are upwards of 80% concentrated THC. And for a developing brain that lives in a state that happens to have a medical marijuana statute on the books and an adult recreational use statute on the books, where, hey, why not? It's legal. That may be the worst. That may be the one and simultaneously the worst decision that particular individual makes in their life. I've seen it time and time again where, a young kid grows up in a fantastic family, supportive parents, both parents around, access to everything they need in order to be successful in life, happens to live in a state where they can purchase marijuana legally, gets one of these concentrates, dab, wax, shatter, whatever it is, right? Psychotic episode, never quite the same again.
Mm-hmm. Mm-hmm.
And you just don't know. There's no way to predict it, right? And so it's a crap shot.
Yeah, good point. Yeah, that's really well said. And I'm glad you pointed that out because, it's almost becoming like a script with certain things of just like, well, we think this is safe, or we think this, instead of balanced views of continuing to point out the pros and cons of all of the use of even CBD, THC products, and to really continue to have that conversation and not get lazy about it just because it's legal now in certain states.
Legal does not mean safe.
Right. That's really a wonderful point. And thanks for answering that question. I know it's I think we're entering into an era where the lines are starting to blur, and if we're already there, I mean, it's not entering. Well, I think, after talking to you, you come across as such like a very human, down to earth person, and like able to hold a space for people, and you really come across that way. I can see why you're successful at what you do. And you're a caregiver, right, for a lot of people. How do you, if you're speaking to like caregivers or friends and family members of someone who's dealing with addiction, like how should they take care of themselves, like, and just how to withstand it? Because there's a certain kind of, they're along for the ride with this, and it can be, even as a healthcare provider, I imagine it's just some heart-wrenching experiences. Like, how do you take care of yourself and deal with that?
So, I mean, it's a great question. And I think the healthcare field as a whole is terrible at self-care, and this notion of, provider, heal thyself, physician, heal thyself. I think we do a horrible job of it as a profession. And I think we do a particularly horrible job of it in behavioral health, where we probably should be doing the best job of all. I learned a long time ago not to take anything home with me, and to leave it at work. And so my boundaries have to be secure, right, and solid, because you hear the most gut-wrenching stories day in and day out. And there's a difference between empathizing with that individual and kind of taking that on. And so I learned that early on. My mentors were particularly useful in kind of guiding me and helping me navigate those early years in the profession. For family members, there are fantastic resources that I don't think enough family members take advantage of, namely Al-Anon or PALS. Al-Anon is a great group of individuals, family members who are dealing with a family member or multiple family members who are in the grips of addiction or alcoholism. And and I don't think this is a resource that's taken advantage of nearly as frequently as it should be. Additionally, PALS is another one of these groups. Where again it's a like-minded group of individuals who have basically formed their own support community, right? So that as individuals, they can find refuge and solace in the act of being of service to another individual or family member who's going through a similar battle or similar time. Interventionists, professional interventionists, have a different way of looking at it. They say that yes, you should have solid boundaries. It's far more challenging to have those boundaries when this issue is going on in your home with a loved one with whom you are emotionally intertwined and entangled. But even then, you must have a line in the sand.
Mm-hmm.
And you don't have to necessarily verbalize that line in the sand, although in the interest of transparency with your loved one who is battling the disease, it would probably behoove them to understand what that line is at some point. Whether they choose to adhere to that or not is a different story altogether. But there has to be a line, and if that line is crossed, you have to be prepared to leverage consequences that you have previously not been able to do for any of a variety of reasons, up to and including cutting that individual off altogether, financially, emotionally, and otherwise. The issue is codependency. There are fantastic books out there on the topic. One in particular called Codependent No More is a great resource that I recommend to family members all the time. Additionally, as family members, you should be seeking your own professional therapists and have your own treatment team, just as you have provided the resources by which your loved one could have their own dedicated treatment team. You too deserve that. And that individual or individuals will work with you on defining some of these things for you. Defining what that line in the sand is if you haven't really thought about it. Kind of even acting out a scenario where you would have to, probably for the very first time, verbalize that line in the sand and verbalize the consequences that you're prepared to leverage on that individual. And acting out, coaching you through the act of being accountable to those consequences.
Right.
And so, and being accountable to yourself. And so there's a plethora of resources and tools out there. I find it particularly effective to seek out treatment facilities that have a defined family therapy unit or module. Some people have a family weekend. Some people, for some facilities, every weekend is family weekend. Other facilities have a family week, where during the course of a week they house the loved ones of the afflicted individual, and spend a week, some of which is spent doing, working with that individual in treatment, and some of that time is spent working with the family members as individuals. Again, to assist them in preparing themselves to define boundaries and hold boundaries.
Very helpful. Yeah, I mean, I think it's really good to hear like a framework and to kind of understand that, that the caregiver has to have a plan for themselves as well. Like, and, just kind of being along for the ride in this journey without any kind of structure in itself is, just like a harrowing journey. Like
It's
to have
traumatic.
that. Yeah.
It's
Yeah.
trauma, right? And it's trauma, and so untreated trauma results in PTSD,
Mm-hmm.
right? Untreated trauma results in many cases, maybe not every case, but in many cases, post-traumatic stress disorder, which is a whole different animal. So,
Mm-hmm.
but yes, I absolutely am of the opinion that the family members of individuals afflicted with substance use disorders are traumatized and
Mm-hmm.
victims of trauma.
Mm-hmm. Mm-hmm. Yeah. Well, so yeah, I think, it'd be really great to kind of have another session at some time to talk about like a dive into like the treatments that you do,
Sure. Happy to.
and could get into that. And I would love to kind of close hearing about the IAM
Mm-hmm.
and
Yeah.
just kind of
So
share with us
sure.
what that is. And
Yeah. Um, I pioneered and founded um, integrative addiction medicine. IM stands for Integrative Addiction Medicine. And so, very early on in my career, um, I determined that, again, as I was dealing with a multifactorial disease process that, in my opinion, and by virtue of my training, was best managed with a multifaceted treatment strategy, um, and determining what the optimal elements of that strategy would look like. Um, I basically took the very best that was available from conventional, right, time tested, protocol derived addiction medicine practice and evidence based complementary and alternative medicine, functional medicine, integrative medicine, and merge them together to form integrative addiction medicine. Um, and perhaps during a subsequent conversation, we can talk about the different modalities. But effectively, it's it's how I was taught to practice. It's how I was trained, and so
it's,
there is a hierarchy of therapeutics, and the very nature of the patient population that we're dealing with have ingested known toxins over a period of years, if not decades. By virtue of that, if we accept that that is fact, then the logical next step is in thinking is okay, then their organs of elimination are more burdened than the average person's, right? Their livers have had to work harder, their kidneys have had to work harder, their GI systems have had to work harder, their skin has had to work harder, their lungs have had to work harder than the average person's. Why in the world would it be, right, across the board, best practice to throw a bunch of drugs at these individuals when we know that those very same drugs, even though they're legal and FDA approved, must go through the very same systems of elimination, organs of elimination that are already taxed and burdened more so than the average person.
mm-hmm.
Instead, we don't discount the value of those things, but we offer as many non-pharmacologic interventions as we can simultaneously or in lieu of, if that's possible.
Mm-hmm.
Acupuncture, massage therapy, other kinds of body work, steam and sauna therapeutics, hydrotherapy, chiropractic, exercise therapy, therapeutic nutrition. I can go on and on and on. You know the list the same as I do.
Yeah.
And so that is integrative addiction medicine. Integrative addiction medicine is meeting the individual where they are, recognizing them as a whole person, not components. Individualizing your treatment plan based on a thorough assessment and understanding of that individual's unique circumstances, leveraging laboratory data, objective data, where and when possible, in arriving at a customized treatment plan that does not prioritize pharmacologic intervention over anything else.
Mm-hmm. Love it. Yeah, I mean, and you're teaching your patients along the way, I'm sure, how to like care for themselves and like love their body in a way that they never have, maybe, or just at least understand how their body works.
Exactly right. Exactly right. In many cases, you're dealing with individuals who have never had the mentors, have never had parents around, have never had anybody to actually teach them to do that. And so you're doing it for the very first time. You're playing the role, if you will, of step parent, right?
Mm-hmm.
This is how you cook for yourself. This is how you do laundry. This is how you balance a checkbook. This is how you shop at a grocery store. Things that they've never been taught. They've only been their role models, for lack of a better word, have been expert at teaching them the wrong things to do.
Right, like self-harm. Yeah. Wow, that's powerful stuff. So is there like a certification program you're offering to providers, or is it sort of just like a framework of practice that you're teaching others?
At the moment, it's a framework of practice. In due course, it will look a little more formalized, meaning that there will be an authoritative textbook, and that authoritative textbook will pave the way for some CMEs, for some specific CME offerings, and those CME offerings may or may not lead to a certification pathway. Not entirely sure if I want to go that direction or not, only because the ASAMs of the world kind of own that space, right? Mm-hmm. And the joint commissions of the world kind of own that space. And it may be enough for me and ambitious enough for me to just get my thoughts on paper and teach the core concepts to individuals that are interested.
That makes sense. Yeah. So how do people follow your work or come see you or your team, if they need help?
They're always welcome to email me. At the moment, I'm with an organization out of Arizona called Soul Surgery. I've been here for some time. So at the moment, I can be reached here. But you have my email, Adam, and my cell phone number. If you're more than welcome to share those to your listening audience. And if they're so inclined, they can reach out. The other thing that I would say is that if I'm not in a position to help them specifically, I have the resources and team members that will go above and beyond to find them the best resource for their specific needs and circumstances.
Excellent.
I'm not the best fit for everyone, and I would be it would be hubris for me to think that.
Excellent. Great. Any closing thoughts or kind of take-home messages you want to share before we wrap up? This has been great. So if you don't have any, you've given us plenty to think about. So, but if you have anything that you want to kind of leave us with to think about, that'd be
well. I mean, I appreciate your bringing this really important topic to your listening audience. This is if there are people out there, I would be hard pressed to believe it, but if there are people out there that have not been individually affected by this disease to date, you can be fairly certain that you will at some point down the road. This disease does not discriminate, by virtue of socioeconomic class, or anything else. And it is something that is going to dominate the news cycle for years to come, particularly given that we have not yet begun to see the longitudinal effects of COVID. We're not entirely sure what we have left to see, what's coming down the pipe. And I think what we'll see is more mental health issues, more substance use disorder issues, more process disorders, meaning that the resources that already exist will be taxed, creating a need for more resources and better resources and more effective resources. And so we have a long journey ahead of us, and we need as many people fighting the good fight as possible.
Yeah. That is very helpful. This has just been an awesome conversation. So thank you so much for your time. Lots to think about here, and I look forward to kind of meeting up with you at some time down the road and talking more about the kind of treatments you do and just anything else we can cover during a future discussion.
Sounds great, Adam. Thanks again. I appreciate your time, and you're doing a great job. Thanks for doing this.
You're welcome, Dr. Ravi, and thanks for being here.
Hey, bye-bye.
Bye-bye. Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from it. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.